Good evening, dear colleagues. Today our webinar, at least unique, as we have one of the most famous surgeons in Germany, Professor Tobias Keck. Professor Tobias Keck is chairman of Department of Surgery, Universität zu Lübeck, and head of University Cancer Center in Lübeck. Yeah. He does research in laparoscopic and robotic surgery and minimally invasive surgery at the University Medical Center Schleswig-Holstein. Wenn ich etwas nicht richtig sagen, kannst du mir. Okay. His main research fields are pancreatic surgery and pancreatic cancer, and surgical clinic of Professor Keck and his colleagues is a center of treatment of diseases of pancreas, and it's renowned across not only in Germany, in Europe, and in Russia as well, and the Ukraine. Especially in surgery of tumors of pancreas clinic in Germany, and performing minimally invasive procedures. So I think a lot of patients have benefits from this surgery in Germany, and this high level of expertise in minimally invasive surgery has given a clinic status of a German Center of Excellence of minimally invasive surgery, and today we have not only Professor Keck as a guest and our great friend Grigory Lapshin from Ukraine, and he working for many years with Professor Keck, and many thanks to him and his family, because they're giving a lot of opportunities for our colleagues to visit and study in Germany in 2000 sagen, ich bin in 2006, yeah? 2006. So I have an opportunity to visit this clinic. I know that after my hospitation or fellowship or observership, we started with Professor Donov laparoscopically pancreas operating, yeah. And I know that your clinic has built a wonderful new building, yeah. And you installed this robotic Da Vinci Xi system, yeah, during this time. So Professor Keck had recently published new book on minimally invasive surgery with support of Russian colleagues and in Russian language. Yeah. So, Professor Keck, ich hoffe, dass unser Webinar heute von vielen Kollegen nicht nur aus der Ukraine, sondern oder Russland und Russland, sondern auch anderen Ländern verfolgt wird. Ja. Wenn es Ihnen also gelegen kommt, werden wir auf Englisch halten. Okay?
Okay, gut.
Ja, ich glaube, ich habe mein Deutsch ein bisschen verbessert.
Sehr gut.
Ich erteile dem Professor das Wort. Dankeschön.
Vielen Dank für die netten Worte und thank you very much for the nice words. Yes, we had the chance to host many of Ukraine and Russian surgeons in our hospital so far, and it always was a pleasure to have you here. And I think after Corona, we probably will have a chance to meet again in person. For now, I think this is a great idea to have a webinar together to keep the connection between surgeons in the Ukraine, Russian-speaking countries, and Germany. So today I want to show you my presentation. I don't see it now, but I think it's okay. Here we go. I want to give you an update on minimal invasive surgery of the pancreas on the one hand, and share with you some videos on robotic and laparoscopic pancreatic head resection, Whipple procedure. And some of you might ask themselves, why do we do an operation this complex in a laparoscopic fashion? So, doesn't work. Okay. The first Whipple operation was performed by Walter Kausch in 1919 in the August Victoria Hospital. This is Walter Kausch. Many of you know this operation today as the Whipple operation, but actually it was performed 30 years before by a German surgeon, Walter Kausch. He has no publication in English, only in German, so almost nobody knows about this. However, this is the original publication from Whipple, who adapted the technology of Kausch and had the idea to connect in a first operation the biliary bladder, the gallbladder, with the stomach or the jejunum, and then reduce liver dysfunction, and in a second operation then remove the pancreatic head. Here you see no anastomosis. Today we have different forms of anastomosis. I will talk about that a little bit later. But in that time, there was in the beginning, in the first patients, no anastomosis used. There's a slight delay in the... Okay. So the mortality in the beginning was as high as 40%. For long, the Whipple operation was not an accepted procedure, and only very rarely this was performed as a radical oncologic operation. And in the beginning, palliative treatment had very similar results, so nobody could really use this operation as a good technique. However, after some years, today we know that the problems are mainly based on mortality and morbidity of the disease, and we know that there is a high correlation between caseload. Very low caseload has a higher mortality, and higher caseload has a low mortality. Today we aim for mortality of 5% or lower. This is not only dependent on the surgeon, but also on other factors, especially on factors like interventional treatment or the availability of endoscopists. So this is the results of our Reconstruction trial, a large multicentric trial where we compared two forms of anastomosis, pancreatic head resection and then the Pancreatic.Tobias versus jejunostomy. And what is important, there was no difference in the two anastomosis, but what is important is this one. We can see that there is a very high rate of complication. In some, up to 40% of relevant complications after pancreatic head resection in forms of intra-abdominal abscess formation or relevant pancreatic fistula, and the mortality in this control study was as high as 6%, which is quite high comparing if we aim for a 5% mortality overall. This is our results in the last years. Now we do over 150 pancreatic resections per year, and the percentage of laparoscopy, this was 2015, was 30%. Now we have almost 60% laparoscopic surgery, and the mortality in our hospital is as low as it's below 5%. Here it was 3.5%. In Germany, we know the general mortality is around 8.6%, although much higher than it is in our collective in Lübeck. So why should we do this complex operation in a laparoscopic way? So there are many factors that are benefiting for patients. It's less trauma, it's less pain, less complications, a shorter length of stay, hospital stay, better cosmetics, less hernia, but it takes longer, and maybe there's additional risk, and oncologic radicality is questionable. You're all aware of the Leopard Trial from the Netherlands that showed that laparoscopic pancreatic head resection had a higher mortality. This was not the aim of the trial, but in the end, this led to the conclusion. It's just one of 3 randomized controlled trials, but this one trial showed that there is a higher mortality rate in laparoscopic surgery, so it obviously has a long learning curve, and we want to think about how to reduce this learning curve. So this is a tumor you can see here, an advanced pancreatic tumor. It's close to the mesenterical portal axis, as you can see here. This is a typical teardrop phenomenon. So the tumor is probably invading the portal vein or superior mesenteric vein in close proximity to the artery. This is a superior mesenteric artery. So this is not a case that we should really start with in laparoscopic surgery. This is also challenging in open surgery. So this is not a case for laparoscopic surgery. Of course, we know from open surgery that these tumors can be resected in tangential portal vein resection. I will show you some videos that this is also feasible in laparoscopic technique, but of course this makes the operation more complex for laparoscopic approach. This is something that we would not consider as a good initial operation for a laparoscopic case. This is another form of resecting this tumor, end-to-end anastomosis here, portal vein by infiltration. So, but there's a large, a big number of patients that we are facing now in recent years that are not necessarily these advanced tumors. We see a lot of patients with cystic neoplasms, serous cystic neoplasms, IPMNs of the pancreatic head, or MCNs. And these patients, of course, have other factors that lead to the operation, and they won't probably have a minimal invasive approach because most of the cases we operate these patients is in a prophylactic fashion, and we do not resect them in oncologic cases. So you're all aware of these tumors. The SCNs, serous cystic neoplasms, they are not so important because they should not be resected normally, only for symptoms. But these two, the mucinous tumors, they should be resected, and they have a high grade of malignancy in some cases, especially if they are main duct IPMNs. And these are ideal cases for the beginner to start off with a robotic or laparoscopic cases. Next slide, please. I have difficulties in my promote. Okay, so these cystic tumors, as you know, they can proceed from normal ductal tissue with the same mechanisms as a pancreatic cancer. We have pan information. The IPMNs or MCNs can proceed to pancreatic ductal adenocarcinoma. So they are normally operated in a prophylactic way, and laparoscopy, I show you in a second, is the best way to do that. So what are the worrisome features that these patients have? You know, main duct IPMN, cystic tumors with mural nodules, a size that is higher than 2 centimeters, symptoms of multilocular localization. So this is a typical case of a main duct IPMN, a large tumor in the main duct here. You can see an enlargement of the duct here as nodules of the tumor. This needs to be resected, of course. Another example you can show in the next slide. This is a solid tumoral nodule, an IPMN carcinoma. Here you can see the nodule Of course, this is malignant suspicions, also a good case for laparoscopic surgery. This is a multilocular EPMN, also suspicious of malignancy, good case for laparoscopic left side resection. And if we resect these patients before they get invasive, so if we operate the IPMNs before they transform to a malignant tumor, we have a good prognosis, almost unlimited prognosis, in comparison to those who are transforming to an invasive cancer, because they almost behave like pancreatic cancer. So we need to resect them in a prophylactic fashion, and this is the ideal indication, to my opinion, for minimal invasive surgery. So let me talk a little bit about the options. We have laparoscopic Whipple operation and also laparoscopic distal pancreatic resection as options for pancreatic resections. So if we do a distal resection, we have to consider spleen preservation, parenchyma sparing operations, or laparoscopy versus open operation. There are some advantages that we can see in these patients. So if we are able to preserve the spleen in laparoscopic distal pancreatic resection, the major complication rate goes down. It's only 11%. It's up to 11% if there's no spleen preservation. And also infectious complications are significantly increased in the patients who have no spleen preservation. So we also know that laparoscopy is a good means of reducing the risk of losing the spleen. So this is a study that compared the ability by laparoscopy or open resection, and you can see maybe because you have an enlargement or you have better view or you have less bleeding, I don't know what is the reason, but we know that in laparoscopic approaches, the spleen preservation rate in distal pancreatic resection is much higher. And for matched indications, only cancer, the difference is also pretty high. So even in cancer, some patients are able to preserve the spleen, which is oncologically questionable, but it's possible, as you can see. So also other techniques like parenchyma sparing techniques, enucleation, untitled or central pancreatic resections, these are also methods that are available for EPMNs and do not need a oncologic resection for all these cases. And of course, these mechanisms can be well performed in a laparoscopic or a robotic fashion. So let me show you an example for this. This is a patient with an insulinoma of the pancreatic tail. Here we do a classical enucleation. Of course, this patient would normally need a left-sided pancreatic resection or some other techniques, and it's ideal laparoscopic operation. You don't need an incision. This patient is a pilot. He was collapsing on the gangway from the plane, and we did not want to overcorrect this patient, because if he gets diabetic after the operation, if we cut the pancreatic tail, this patient will probably not be able to fly a plane again, on the other hand. So we don't want an overcorrection. This is the tumor, ideal case for enucleation, ideal case for laparoscopy, sonographic control. So we look for the pancreatic duct. Is there a connection to the pancreatic duct? Do we risk, if we now do an enucleation, do we risk to open the duct and have a disconnected duct syndrome? We don't want to open the main duct here. So we're controlling where is the main duct, and it's far away from the tumor. Then we do here with a ligature instrument an enucleation of the tumor. You can see here it's a little more bloody than normal, but it's a good opportunity for laparoscopic resection without opening the main duct. Okay, so nobody wants a big incision for this small tumor. I think it's an ideal indication for minimal invasive pancreatic surgery. And these parenchyma sparing techniques for IPMNs are very good. As you can see here, this is the publication from a French group, Sauvanet and co-authors, and they found that if you only look at tumors IPMN over 3 centimeters, mural nodules growth, so really strong indications for resection, and they did not operate for suspicious tumors, but only for these tumors, and did a local resection, parenchyma sparing operation. And you can see here that the progression-free survival after 1 year is 100%, after 10 years it's still 76%, and if only a few patients had to be reoperated, and what is most important, the risk of diabetes is only 4%. So if we do a left side resection, these patients, many more patients will have obviously problems and diabetes. As we know from left side resections, up to 70%. So for distal resection, we also know that blood loss is lower, long length of stay, complication rate is lower, wound infection rate is lower. So many advantages, and also we have randomized controlled trials in the Leopard 1 trial that shows that it's really equivalent to do a laparoscopic operation compared to an open operation. As far as complications, we are now participating in a randomized controlled trial from the Netherlands, the called Diploma trial, where we compare the result of oncologic resection for left-sided tumors in laparoscopy versus open surgery, but this trial is still running. So let me put this together. Here you can see, one more slide. The OR time, everything is pro-laparoscopy. In this meta-analysis, and here you can see the factor of length of hospital stay, also pro-laparoscopy. This is again for laparoscopy oncology. Of course, this is also pro-laparoscopy, but of course this is a selection. You know, I showed you in the beginning tumors that are selected because of proximity to the mesenteric-portal axis, close to the mesenteric-portal axis coming from the left side. They are probably not included in this study. So this is no randomized controlled trial. It's just a retrospective series, but all favor, in any case, laparoscopy for left side resection. We also looked at our registry, the German registry, Studok. Some of you are participating in it, and it's the same. This is this is just a registry study with over 2,000 patients, 80 hospitals, and you can see here this is not only specialized hospitals but also smaller hospitals that include their patients, and it's the same reduction of length of stay by 4 days if you do a laparoscopic operation. This is the same in other studies. Again, length of stay and spleen preservation are benefits of laparoscopic left side resection. We have seen a change of indication in the recent years. So after a learning curve of over 2 years, this is Charlson score is a complexity score for comorbidity, and you can see that after 2 years, more sicker patients were operated, larger tumors were operated, and also tumors were operated that are proximal, so very close to the mesenteric-portal axis. This is for cancers only, and you can see after a learning curve of 2 years, the indication was moving to more complex operations here close to the mesenteric-portal axis. So this is an example of laparoscopic distal pancreatic resection. You can see here, this is a patient, a young woman with a cystic neoplasm of the pancreatic tail, a mucinous cystic neoplasm. So the indication is clear, and in this woman, we don't want to sacrifice the spleen. We don't want to sacrifice the whole left pancreas. We only want to concentrate on this tumor. So we do now laparoscopic spleen preserving operation. Here you can see the lower border of the pancreas. We then go from the lower border to the splenic vein. This is our first step that we approach normally. We mobilize the splenic vein over a long distance. You can see here it's sometimes a little bit in the parenchyma, and we cut it out. This is a bipolar scissors. We prepare the artery. This is the splenic artery. Here is the splenic vein. And we now have very good instruments, as you know, all that are able to dissect smaller veins with a very high reliability. And so we can cut here the tumor in a very preserving way. We only cut a little bit of the pancreas, and this woman is not losing a lot of tissue. It's only very small tissue that she's losing. We use a covered stapler, and of course this is an ideal indication for laparoscopic approach again. We use this covered stapler. Some of you know it. I think it's a good idea to have a covered stapler because there's no breaking of the parenchyma. In former times when we used the stapler, we had always a little tears here at the parenchyma. I think this can be prevented. And then there's a smaller vein again, and we take it out. So this is just a small parenchyma loss that we are seeing in this patient. Good. Let's go. Let's move to the next slide. So this is the tumor. This is again for oncology, for left side resections. Lymph node is similar, radicality is similar. 6 months a month follow-up shows no significant differences, but we have to wait for the diploma trial that is showing us this in a randomized control trial. So far, there is only retrospective data. Again, another example, oncology open versus miss in this single center series, similar. So what are the advantages for distal pancreatic resection? The spleen preservation is important, and parenchyma preservation is important. I showed you this. So we have different techniques of parenchyma preservation, spleen preservation. Laparoscopy shows similar results in oncologic radicality. It shows more spleen preservation and more parenchyma preservation, less complications, but the same fistula rate, a shorter length of stay, and laparoscopy is therefore for the distal pancreatic resection should be the choice that is the choice of options. So what about the pancreatic head resection, the laparoscopic Whipple? This is a much more complex operation because it has a big part of reconstructive work. So it's not only a resection that you staple the pancreas, but you have to do a lot of reconstruction in these patients. So what is the data? For the recent years, you can see here, this is the year of the publication. It goes now up to a lot of publications, but you can see here the series that are really publishing a lot of cases. This is the number of cases in a single series. The most of the cases are here. I've done one, I've done two, but it's not a large series. And here you can only see a few series that have higher numbers. So what are the advantages? This is a publication from my former co-worker who is now chairman at Ruhr University in Bochum. He showed that in this meta-analysis that there is a same resection rate for R0 resections, the same lymph node ratio in these patients, and also on the next slide, morbidity and mortality are comparable in these patients. So there's no difference, but it's selected cases. You know this. This is not the big pancreatic tumor after neoadjuvant therapy. These are selected cases. So this is an example. We did the first laparoscopic pancreatic head resection long time ago, 2011. Currently, we have over 100 laparoscopic head resections. And this is what is important. Here, you can see the superior mesenteric artery, and you have to use the same rules that you use for open surgery. So there must be a close preparation to the superior mesenteric artery. You have to see it all the time. This is the superior mesenteric vein, and of course there cannot be a reduction of oncologic radicality. And this is the result in this patient, a small retrieval resection. These are our access points for the laparoscopic approach. On the next slide. So here we can see what is the data. There is not much data, actually. It's only retrospective studies. Lymph node and arterial resection. In these selected cases, there is no difference. We put this together in the laparoscopic. This is our experience from our hospital. Also, resection margins, no difference in this early series that we published. This is actually our learning curve that we published at the time, and there was no difference between the tumors. Also here, we looked at the infusion rate, laparoscopic open versus laparoscopic. Here's the transfusion rate, and you can see there is a little bit higher percentage of transfusion rate, but it's just a low number. And also here you can see the overall hospital stay a little bit lower, but not significantly in this case. Less blood loss, shorter length of stay, ICU and longer length of stay together in the laparoscopic group. The early phases already. Complication rate, also comparable, no differences between laparoscopic and early open resections. So again, let's go back to this tumor, an advanced pancreatic head tumor. I showed you this. So these tumors are difficult to operate, of course. Most cases now they are treated with a neoadjuvant therapy, and that makes laparoscopy much more difficult. But if we look now at portal vein resection, the largest series of portal vein resections has been published by Mike Kendrick and his group. They did 11 portal vein resections. You can see here pictures from his publications laparoscopically, and we compared it to our open experience with 160 open portal vein resections at that time. And it's really interesting because the operation time is almost the same, blood loss is almost the same, arterial resection is better in their series, and morbidity is almost the same as mortality is as well. So it's feasible to do also complex cases by laparoscopy. It's not only the small cases that you can operate by laparoscopy, you can also do a lot of complicated cases. What is more important is hospital volume. As you can see here, high volume centers have a mortality rate of under 5%. And if you go now to the higher volume or the lower volume centers, you can see that these have a much higher complication rate, 20%, 90%. So you need some kind of interventional treatment, because we know the complication rate is probably the same between the two centers, but we have no ability to treat these patients in the small or low volume centers. And this is also a question of hospital surgeon volume. So you can see here, the more experience a surgeon has, and this is still a super low experience in all cases, but the more experience a surgeon has, the lower the complication rate is. And now the question is, how could do a laparoscopic pancreatic head resection? Because how many cases do we need? This is something we don't want to see today, that we have a readmission rate of 30%, high blood loss, long operation time, length of stay, which is the same as in open. I think there's no benefit in publishing these results, and you really have to think about how many patients do I need for to make a good learning curve. And you can see here, this is a publication from the US, and they looked at the cumulative data from the NetScript database, and you can see here that this was here the 30-day mortality was twice as high in the laparoscopic group. But if you look at this publication, you find here that 92% of the hospitals who did minimal invasive pancreatic head resections, 92% of these 1,000 patients, they were operated in hospitals that have less than 10 operations, not laparoscopic, in total over 2 years. So very low volume hospitals. And I don't think this is a good indication that you do this operation in a very low, super low volume hospital. So if we look at the same data again, same analysis, and they cut out the super low volume hospitals and only counted institutions with more than 10 laparoscopic Whipple resections per year, they had the same morbidity and mortality. So it's really a question of the learning curve, and we have to work on this together to really shorten and flatten this learning curve. So how long is the learning curve? If you look now here for pancreatic head resection, we have, this is a study from a Korean group, and you can see here they looked at 100 operations and divided it in 3 thirds. And you can see here between the first third and the last third, there was a significant reduction in operation time of almost 3 hours. The complication rate went down, and of course the length of stay went down. These were almost no malignant tumors, only 7%. IPMNs, good idea, good indication to start a program and to really lower your complication rate. This is some results from oncologic data. This is again the study from the group in Mayo, from Mike Hendricks' group, and you can see here this is a total laparoscopic Whipples versus open Whipple, same survival time and same progression-free survival in these patients. And they looked at the other data, and what is interesting, that could find that in the laparoscopic group, mainly probably because of less wound infections and infectious complications, the access to chemotherapy was much better in the laparoscopic group. So they had a better access to chemotherapy and an earlier access to chemotherapy. So they were able, in the laparoscopic group, more patients could receive the whole treatment to adjuvant therapy, not only the operation. So this might also contribute to oncologic results. So let me sum up for the minimally invasive surgery of the pancreatic head. Mainly it's concentrated still on selected cases. There's a few centers in the world that do everything by laparoscopy, but it's really not a lot of centers do portal vein resection and other things. The feasibility has been shown for these complex things, including arterial reconstruction or portal vein resection. You need a large caseload. I showed you our results. We started off with 30% from our 150 patients laparoscopy. Now we do 150 patients, 60%. But you can see this is still only around 70 patients probably per year. And you need this number to overcome the learning curve. You need a high hospital insertion volume. It needs to be oncologic safe, and we have to put our data together in a registry. Some of you are participating in this already to really see whether we have a good benefit for our patients by laparoscopy. So we invite you when we can travel again to our workshops. We do this here, as you know. Some of you have participated in our workshops. Once we are able to travel again, this is our new hospital, our lobby here. This is the new hospital, 20 new ORs, and we are able to really show you some pancreatic laparoscopic surgery when we are able to travel again. Now I'm open for your questions.
Thank you very much. Very nice, very interesting presentation. It was. We have a lot of new and good information from you, and we have some questions. And first, we have, if you know, YouTube and Facebook audience, and about 200 people are watching us online, and some of them want to ask you some questions, and I will ask Kirill to ask some questions from our audience. Kirill?
Yes.
Кирилл, звук.
Звук.
Sorry, did you hear me? So the first question was in Facebook about some advantages of RAM's technique. It's I think this guy who answered, he asking about cancer. Yeah? So any advantages for laparoscopic ramps?
Laparoscopic ramps. So this is part of the diploma trial that is currently running. So the diploma trial compares, on the one hand, the open access, and randomized, on the other hand, the laparoscopic or robotic access for left side resection. And in all patients, it's very formalized. You have to have a RAMS procedure, so-called RAMS or Strasberg procedure. And the study is not finished yet, so we don't know it because we don't have the randomized data yet. But we are including all our patients into this trial because we want to know. I think it's 15 centers. It's led by the colleagues from the Netherlands. They are the main principal investigators, and it's an international trial, and we have to show that we are able to do it in advance and videos and everything. So it's a control trial that also is excluding non-experienced centers.
Thank you. And have you any opinion why they have only few trials since last 10 years? Randomized control trials for cancer. So it's known that benign diseases are mostly operated laparoscopically, but for cancer it's only few trials. Have your opinion?
Yeah, I mean there is 3 prospective randomized trials that are comparing for cancer in pancreatic head resection. One trial is done by Boves. He showed that it's a superior for the laparoscopic group in his own single center experience. Very good laparoscopic surgeon he was. So he was able to do it in a really very skilled way. The Papanolivelo trial also showed an advantage of laparoscopy versus open operations. Also, single center, one surgeon, very experienced, but not prospective randomized. You cannot transfer it to general auditorium. The Dutch trial, the Leopard trial, was a multi-surgeon trial. After a certain learning curve of 20 operations, I think it's much too low, 20 Whipples, and then they started to randomize, and they found out that the mortality is higher in the laparoscopic group. I think this is a question of learning curve. I showed you the Korean study, it's around 60. I think the 60 is the learning curve you have until before you can start a randomized control trial. So I think it's very difficult. It's only a few surgeons in the world who do it, and it's very difficult to reach. And I'm not sure whether it will really reach the broad audience of pancreatic surgeons in the world, because this is only performed in very high volume centers. So I'm not sure whether it's really transferable to the general surgical auditorium.
Dear Professor,
I will give a word. I will give a word to Artyom. He have a lot of questions from YouTube. Okay.
we have some questions from YouTube, and question from Alexei Sakharov from St. Petersburg. Dear Professor, do you have difference in operative time by laparoscopic and open Whipple? Mean you personally, operative time.
This is a very good question. So in the beginning, I had the first Whipple I performed took 14 hours. So it was very long, painful. But now operation time is 340 minutes, so it's the same in open and laparoscopic surgery. Of course, it's a long way to go, but now it's the same. In the beginning, it's really painful to learn it.
Thank you. The next question from Anton Tur from Minsk, Belarus. Are there any tips how to treat stapler line to reduce rate of bleeding or fistula formation? maybe some tips and tricks.
Okay, so what you know is the Distal trial. All of you know the Distal trial. It's a comparison between stapler and resection and suturing. So for distal resection, and I'm convinced that it's important which stapler you use and which cartridge you use. And in this case, it was just a normal stapler, and I don't think stapler is the same as every stapler. So we prefer now, because we have the best experience in my personal series. I don't have a randomized controlled trial, but we prefer a large cartridge, black cartridge, for the stapler size, and we prefer a covered stapler that you can either have a pre-covered stapler or you use a cover, which is seam guard or other covers you use, and then you have less breaking of the parenchyma and less bleeding from the staple line.
Thank you. And the last question till now on YouTube. Can the high spleen preservation rate in laparoscopic distal pancreatectomy can be the result of patient selection for laparoscopy?
I think for non-cancer, the laparoscopic spleen preservation is the choice of that you should do. If you don't have a cancer or cancer suspicion which is close to the vessels, you should do spleen preservation. There's a series that compares the Warshaw and the Kimura procedure. The Kimura procedure is cutting the artery and the vein, preserving the artery in the vein, and the Warshaw procedure is cutting it and only preserving the short gastric vessels. And as far as I know from this series, there's no difference in a large series comparing these two techniques. But it's always worthwhile preserving it.
Thank you. We have some questions from Facebook. I think 3 questions. Is borderline resectable case? Do you prefer laparoscopic approach or open one?
We prefer open because we do have. I show you in a video in a few seconds. I show you how we perform a portal vein resection laparoscopically, how we perform it in the robotic technique. But this is cases that are not intentionally operated for advanced cancer. So it's just a case that we started laparoscopically and then we find, oh, we don't know, it's a portal vein invasion. So we finished it. But normally we select the patients. If we have borderline resectability, we do remove the, we do an open operation. 1 second. Okay, sorry.
Yes, I think, and the last question from Facebook, from Alexey Balmasov from Russia. What is the survival rate among patients with vessels involvement, portal vein or superior mesenteric artery? And what is your option about surgery indication in this patient group? Thank you.
So portal vein invasion is separate. So portal vein invasion is a technical question. Portal vein invasion is not oncologically irresectable. Arterial infiltration of the mesenteric artery or the celiac trunk needs, to my opinion, always pre-treatment by neoadjuvant therapy, and then maybe if it's resectable or borderline resectable, re-exploration and resection, open, not laparoscopically. And but venous infiltration is more a technical question, not an oncologic question.
I will ask another question. Did you see any difference when you start neoadjuvant therapy for pancreatic cancer in laparoscopic way? The percent of this patient is higher or no?
We intentionally do not use laparoscopy for borderline. We do open operations, but I think it's safer and it's many complex cases with a lot of reconstruction. So we do some Appleby operations in a minimal invasive way. I'll show you a video of that. But most of the cases we really do an open operation if we have borderline resectable cancer.
Okay, and some questions from Swiss. Here is Sabrina Del Pino Barbieri. Maybe I. So hello from Switzerland. Thank you very much for a nice presentation. I'd like to know which is your opinion regarding the learning curve in laparoscopic and lap-assisted Da Vinci distal pancreatic resection. Would the robotic approach tend to flatten the curve? Thank you.
I think the distal pancreatic resection is a good procedure for if you are an experienced pancreatic surgeon and you want to start with a Da Vinci system. I think the distal resection is a good approach. Maybe start with benign indications or neuroendocrine tumors or cystic neoplasms. So I think this is a very good indication. The learning curve is probably, according to literature, around 30 cases.
Thank you. I give a word to Ilya Gatsadze.
Okay.
Yeah.
I just was listening to your lecture and wrote some questions here. So you told us that the mortality in general mortality in German 8-9% after surgery for pancreatic cancer. So can you please tell us about some words about the selection of the patient? So are there any category of the patients that you don't operate because of the biology of the tumor? And what are the surgical contradictions for the pancreatic head body tumors? So in what cases you do not operate the pancreatic head and pancreatic body cancer?
Okay, thank you for this question. So if we have an infiltration of the hepatic artery or the mesenteric artery, I think it has to be regarded differently. If you have an infiltration of the hepatic artery, you still can perform a resection with an arterial reconstruction if you do after neoadjuvant treatment. If you have an infiltration of the mesenteric artery, this is very rare that you get a secondary resectability. So we do not treat these patients normally with a resection. However, we do a lot of arterial reconstruction in the pancreatic head tumors. If we do a hepatic infiltration, in some cases you can do a so-called Appleby operation. You cut the celiac trunk and the perfusion of the liver artery is then done via the arcade between the superior mesenteric artery and the gastroduodenal artery to the hepatic artery. You don't need an anastomosis. So if we do neoadjuvant treatment for borderline resectable cancers, if the cancer is stable and if the cancer is smaller, we do a re-exploration. And in these patients, in around 70%, the tumor can be resected. If the tumor is growing during chemotherapy, or if the tumor is building metastasis, then we do not do a re-exploration.
Okay, thank you. Last years, we hear some kind of nihilism from our colleagues. Some of them do not believe that it is necessary to operate the pancreatic cancer because of the poor prognosis. The majority of a lot of things were made to improve the survival in the pancreatic cancer. So surgeons perform wonderful operations, and we know about some prospective schemes of chemotherapy, for example, FOLFIRINOX. But I would like to ask you one question. What is your hospital's evolution in the neoadjuvant treatment of pancreatic cancer, and what scheme do you use for it, and what are your results? And do you still think that surgery of the pancreatic ductal adenocarcinoma can be improved by chemotherapy or surgical combined treatment, or it's the maximum for right now? So how can we improve the survival in these patients? What do you think about it?
Also a good question. Let me give you two examples. So I want to give you one example of a patient who came to me with a central pancreatic head tumor, 38 years old, family father. The mother was pregnant, and he was coming irresectable, infiltration of the celiac trunk. So we did neoadjuvant treatment. The tumor was stable. We resected the tumor. It was a YPT0, complete response to neoadjuvant treatment. He is now living with an 8-year-old daughter and visiting me every year here in Lübeck. So this is a patient that is a good example why we should really give everything to put into the basket for pancreatic cancer. Of course, I have maybe 50 or 100 patients who are not surviving such a long time, but still this case or a few cases similar are really important. And I think if we get better neoadjuvant therapy in combination with our good surgery is already, I think, at the limit. I don't think that we can improve much in the surgery. Maybe make it less complicated or make less complications, but I think we cannot improve the radicality. I think if we have a good adjuvant therapy or neoadjuvant therapy, I think we can improve the results. And we have improved the results already. If you look at the last 20 years, we come from a survival rate of 5 years, survival rate of 5% of the radical resected tumors. Now we are up to, in some series, 40% 5-year survival rate in radical resected pancreatic cancer. So real R0. So this is something that is important. Second case I want to show you is a patient that we operated. It's a industrial CEO from France. He came here. He had 1 liver metastasis, pancreatic cancer, small cancer, but 1 liver metastasis. So he was treated with FOLFIRINOX pre-treatment. The liver metastasis was getting much smaller, almost invisible. It was in segment 2. The tumor also went smaller. We resected the patient, pancreatic head tumor, still viable tumor, but significant reduction of viable tumor cells. The liver metastasis, no more tumor cells. We then did an immunological classification of the tumor. He was PD-L1 positive. We did immune therapy with this patient. And now he is still alive 4 years after the operation with a metastatic pancreatic cancer. So we have to rethink our concepts for pancreatic cancer because not every cancer is same. So we have some biologically good cancers that can be treated by good means of therapy, combination therapy, chemotherapy. Maybe in some cases immune therapy is not very common, but in some cases and radical surgery. So, and then we will improve our results.
Thank you. Seems to be very we hear very optimistic words, and it's very fine for surgeons because unfortunately more oftenly I see the progression of disease during first year or maybe a year and a half after operation, and after this I feel myself very pessimistic.
I know, because you have to hold on these few cases that are positive, because otherwise I agree with you that there are many patients who have a bad prognosis, but these cases show that we have some possibilities to improve the survival of these patients. and you cannot say in advance who is benefiting or not from this therapy, and that's the main problem. Maybe at one time point we are able to stratify for good and bad prognosis, then it's different. But for now, I think it's not.
Okay, maybe in the nearest future we'll find some biological or maybe some kind of markers that will tell us about the group of the patients with a good prognosis. For example, like MCI high patients in the colorectal cancer, because I believe that some of them sometimes we have to risk their lives when we make great and big operations on the somatically poor patients. Unfortunately, in our scenario, a lot of patients coming to us with a great big tumors, with a weight loss, and with a lot of problems. And sometimes surgery is more harmful for them than their cancer because of their bad somatic status. And one more question, please. It's when we perform the operations on the pancreatic head, or maybe distal pancreatectomy or Whipple procedure on the pancreas, I suppose that the most important and severe problem of the patients is the pancreatic fistula. And sometimes we have great bleedings in these patients. It's our second webinar on the pancreatic cancer. And during the previous seminar, our audience asked how to avoid fistulas, and if you have fistula, how to avoid bleeding. So you are one of the most experienced surgeons in Europe in pancreatic cancer, and don't you have any kind of reset how to avoid bleedings and how to treat them if we have relapse of the bleedings?
So I showed you the results of morbidity and mortality, and I'm convinced that you need a good intervention team in the case of a complex pancreatic fistula. So if we have an erosion bleeding from pancreatic fistula, we have an interventionalist who does do the job and coil the vein or to put a stent, ideally coil the artery or put a stent in the artery. So interventional treatment for erosion bleeding is really important if you have it. If you operate these patients, it's mainly catastrophe and very difficult to handle. For the anastomosis, maybe we can, as a next step after this discussion, look at the different forms of reconstruction, pancreatic gastrostomy versus pancreatocephalostomy. I think these are different forms of reconstruction, and especially for the soft pancreas, which has a high rate of pancreatic fistula, in our experience, we have been moving completely to pancreatogastrostomy for the soft pancreas. For the hard pancreas, I don't think it plays a big role, but for the soft pancreas, we have been making very good experience with this form of anastomosis. As far as bleeding prevention, I think there is not much evidence for this. Some people use patches from the falciform ligament and put it around the stump of the gastroduodenal artery, or they use coverage with peritoneum or with omentum. I don't think this is really leading to much, and also some companies try to sell hemostatic material. I think the evidence for this is very low. So the best bleeding prevention is to prevent a pancreatic fistula and do a safe anastomosis.
Thank you very much. I'm sure that our audience waited for your videos, because the most main part of our webinars is just to show the videos of our experts. So I suppose that there is time to start to see surgery. What do you think about it, guys?
Should we start with laparoscopic video? Laparoscopic?
Yeah, or we can maybe start with the pancreatogastrostomy and jejunostomy because we were talking of fistula. Do you have it or?
Окей. Миша, там открытая есть операция.
Ну, пока маленькая пауза. Профессор Кек нам покажет сегодня несколько видео своих. Это будет видео реконструктивного этапа ПДР, а также короткие видео лапароскопических и роботических операций. So I told our audience that you prepared for us some videos. So let's see that.
So this is okay. I don't see the video. Can you see the video? I don't see it at the moment.
Миш, видео не видит профессор.
Okay, now I see it. Okay, so this is a technique of the pancreatogastrostomy. I told you that we are using this for soft pancreas. So we do two incisions, one on the front wall, and this is the back wall of the stomach. We do a small incision. It's only a few centimeters, and then we do a purse string suture inside the pancreas. Here you can see the hole in the back, and we do a purse string suture here with this is a PDS suture, 2-0, pretty thick suture and open. This is just an open case. I'll show you some other cases as well. And here in the back you can see the hole for the pancreas. And here you can see the purse string suture, and this is the hole. And then we use a clamp to invaginate the pancreas. This is the mobilized pancreas here. You see this, the hole is not very big. It's a pretty small hole here. We invaginate it. And we can also do this laparoscopically, as I show you in the video. But it's easier to see it here. We do an invagination. And we put the serosa and muscularis of the stomach over the pancreas. It's a little bit tense, but it's its purpose, so it should be close, nice and tense. And then we really can put the pancreas far into the stomach, 2 centimeters. And now this is a small pancreatic duct. You're almost not able to see the pancreatic duct in this patient. In this patient, very small, very difficult for a duct mucosa anastomosis. And then we use different sutures. Here is an opening you can see. So we use, in this case, several sutures between the parenchyma and the muscularis of the stomach. Here you can see very small duct, almost not visible. It's very difficult for duct mucosa anastomosis, but you don't need it here. We don't want to close the duct, so we put a small probe not to close the duct, and then we finish these sutures here around, and then we close the purse string suture. You can see here this is the second row now. The purse string suture is closed, and by this we can really then close the front wall of the stomach with the running suture, and the pancreas is inside. So I want to show you why I like this anastomosis. This is a young woman who had a ruptured pancreas. Car accident, ruptured pancreas. You can see here pancreatitis, and we again do the same ventral incision, dorsal incision. This is again our posterior incision, and this was the rupture of the pancreas. There was only the capsule existing, so we closed the remaining pancreas to the pancreatic head by running suture, and the pancreatic tail is invaginated, the same as I showed you before. This is again a purse string suture with a 2-0 PDS. And this was a very difficult pancreas for any other form of reconstruction because it was inflamed, pancreatitis. And then we put this into the stomach. Here you can see again far invagination, 2 centimeters. Again, we do purse string sutures and single sutures. Here it's important to see the wall of the stomach. And then we adapted this technology for laparoscopic approaches because it's as you can see here, it's another form of suturing in comparison to the jejunostomy. We do a more vertical resection. And in the beginning, when we started laparoscopic surgery, we used this anastomosis via a very small incision. To reconstruct because it was difficult for us anyway to do the resection laparoscopically, and we did not want to do the reconstruction in the beginning. So our learning curve in the beginning, we did a hybrid resection just to keep good results. This is the pancreas now invaginated. You can see here, this is the suture line. This is in a robotic case. You can see here it's the same technique. We do here the incision on the posterior wall. We made a little modification because we do not do the anterior resection necessarily. The suture is outside. Here we do anterior resection. We pull in the pancreas in the stomach, far in. We close the suture line. And then we close the ventral incision. Also very easy, but not as complex. So these are different techniques of pancreatogastrostomy that we led from the open fashion to the laparoscopic and robotic fashion for reconstruction.
So if I got you right, in some cases, in the cases of the soft pancreas, we perform pancreatic-ostomy. And what are the problems during the post-operative period when you make such a kind of procedure? So are there any specific complications? For example, bleeding from the pancreatic head?
Yes. So the risk of bleeding is higher. We have, in some cases, we have found intragastrial bleeding from the cut surface of the pancreas. So there is the arcade on the left and on the right side, and you have to suture it and close it tightly. Otherwise, you will have some bleeding from the arcade that come on the left and the right side of the invaginated pancreas. If you have a bleeding after the operation, there's 2 ways to deal with it. One way is to do endoscopy, but this is sometimes very difficult because the stomach sometimes is so filled with blood that the endoscopists cannot see anything. So they look inside and they just see the big coagulated blood and no bleeding. So because normally the bleeding is not so relevant, it's a bleeding that continues over hours, and then a large hematoma is building inside the stomach. So for the endoscopist, it's sometimes very difficult to have a good visibility. And then what we do now, if it's an early bleeding, within the first 2 days after the resection, we reopen the pancreas. We look at the pancreas and do a focused bleeding control by open operation. So, but this is a rate of around 8% of the patients. It's higher than in jejunostomy, they have bleeding. However, in our experience, the fistula rate for soft pancreas is much lower. We could not prove this in our randomized controlled trial, in which many centers participated, but the fistula rate is lower in our experience.
Thank you very much. Are there any questions from our audience, Kirill, Artyom?
I think we have questions to Grigory Lapshin about. Everybody asked, where can we buy the book of Professor?
I don't know now, but I think it will be possible in 2 or 3 weeks.
Okay, thank you.
Okay, then we can start with another video. Another video will be the laparoscopic pancreatic duodenectomy, yes?
Okay.
Please, you're welcome.
So this is a laparoscopic pancreatic head resection that we performed. So this is the CT scan of the, you already know this tumor. I showed you this picture before, so it advanced pancreatic cancer. And we thought that it has a portal vein infiltration maybe, or proximity to the mesenteric or portal axis, but it was not like this. So the patient positioning is normally in a V-shaped positioning. We open the lesser sac, as you can see here. We preserve the arcade of the lesser sac. And we cut the here the right colon is put down. The patient is in a little bit anti-Trendelenburg position. Here we go to the lymph nodes. This is also, the colon is now down. You can see the gallbladder in the background. Here we do mobilization Kocher maneuver. The duodenum is elevated here.
Can you please tell us some words about the cutting device you use?
Yeah, this is a bipolar.
Today Medtronic is a sponsor of our webinar and supports us today, and it will be great if you tell some words about it, please.
Yeah. Okay, so this is just a bipolar scissor. We use bipolar scissors because we have no risk. This is a lymphadenectomy below the ligament. Can I pause the video for a second? Can you make a pause?
Misha, останови видео.
About the instruments, because I don't want to miss on the procedure. So the instruments we use is bipolar scissor in most cases, bipolar Maryland in some cases for preparation, and for the dissection we use a bipolar dissection device from Medtronic, and this is the old Ligasure dolphin tip. I like this instrument because it has 2 branches, and one branch opens and the other one is stable. So if you now look exactly at the video and some preparation features, you will see that I use the instrument with a fixed side to go underneath the tissue, and then only the upper part is opening, and you can go really straight on the dissection. I like it. It's an old instrument, but I still like it, and it has a small tip that is you can do a good preparation with it. And I really love bipolar instruments because I don't have too much heat going to left or right side of the dissection plane, which is very important, I think, for the dissection close to the vessels that we are seeing in a second. Okay, now we can go back to the video.
Миш, запускай, пожалуйста. Миш, запусти, пожалуйста.
So here you can see now the preparation on the hilum. This is the gallbladder that we are taking out. I sometimes leave the gallbladder because it helps me to lift up the whole hepatic duct. Here we do lymphadenectomy below the gallbladder, and then we cut it. I cut it sometimes below the insertion of the cystic duct because I can still move it then here. You can continue the lymphadenectomy here. This is the hepatic duct, it's already cut. And we continue lymphadenectomy towards the portal vein. And this is now again preparation on the gastroduodenal artery here. These are the lymph nodes below. We prepare the gastroduodenal artery. This is now the portal vein coming up. Here you can see the portal vein. take these lymph nodes. This is the cava portal vein. Here we do dissection. This is the right gastric artery that has been divided with a clips. And we've continued a lymphadenectomy on the upper border of the pancreas. These are the superior pancreatic lymph nodes. And we prepare towards the celiac trunk. And here you can see the instrument again. It's very nice for also sealing lymphatic vessels. Here we have the right hepatic, the common hepatic artery. These are the lymph nodes. They are taken out and put into pathology. Now we prepare the gastroduodenal artery. The tumor is pretty close. You could see this on the CT scan. It's here in the upper part. It's pretty close to the mesenteric-portal axis. So here you prepare the portal vein. This is now, we test it. You know, this, we just close it, test whether there's a pulse remaining to avoid a so-called Dunbar syndrome. We cut it. Gastroduodenal artery is cut. Continue lymphadenectomy towards the celiac trunk. This is the hepatic artery here. This is the pancreas on this side here. And now we do a post-pyloric dissection of the duodenum. Normally we preserve the pylorus. And now we prepare the first jejunal loop. We are now under the colon. We prepare the first jejunal loop. Here is the ligament of Treitz, you can see, and we cut again the jejunum. We go here to the mesenteric root. This is here the last steps, and we have prepared an extended Kocher maneuver from the other side. So now we go from here to the duodenal knee. This is a step that is very difficult in robotic surgery. As laparoscopic, it's much easier to prepare this. In robotic surgery, we do the preparation from the right side of the mesenteric root, not from this side, and pull through the whole specimen. So now we prepare towards the pancreatic head, and we put through this cut. We pull down the colon again. Now we go to the other side. We pull through the duodenum. And now we go, this is the vein you can see here in a little second. And now we go directly on the vein. We undermine the pancreas here. So here you can see the superior mesenteric vein. And now there are different methods of cutting it. Either we use a stapler and open the stapler again on the stapler line in the middle where we have the pancreatic duct. This is also a method to prevent bleeding in pancreatogastrostomy. So if you now cut it with a stapler or you cut it open, here this is the pancreatic neck. We cut it here with a stapler and then secondary open the stapler line before we do a gastric invagination. Only in the middle of the stapler line, only where the duct is. So now we have divided the pancreas, and now we go. The pancreas is pulled up. The assistant pulls over the portal vein, as you can see here, and we go directly on the superior mesenteric artery. So this advanced tumor, you can see there is some adhesions, and in the top part where we had a teardrop. I was not sure whether we had a portal vein resection in this case. It's going pretty close to the vein here. So now with lymph nodes underneath the portal vein. And you have a good visibility. You can see here, these are these lymph nodes going to the mesenteric artery. Some branches, but we were able to remove it without portal vein resection in this case. So, and clip some smaller branches.
Wonderful. wonderful visibility of the posterior part of the vessels, because in the open surgery we do not observe this clearly.
Yes, you always look from above, and here you look from below, so you really see the lymph nodes very close. Okay, now this is removed. The specimen is put in the upper abdomen, and we prepare for the pancreatogastrostomy. So for the pancreatogastrostomy, you need to mobilize the pancreas for 2 or 3 centimeters. This is important, otherwise good invagination cannot be reached. You can see these small vessels here. They have to be divided up. Branches from the so I show you some different reconstructions. This is the first hepatojejunostomy. So you can see here a very small pancreatic duct, a very small bile duct. You can see here in this patient. And there are different methods of reconstruction. So either you use a stent. Normally for reconstruction in these patients, I use a stent. So you need to either fix the jejunal loop here on the liver to reduce tension during the reconstruction, or you have a good assistant who pulls it up. Because if you have too much tension between the jejunal loop and the small biliary duct, you will get tearing of this. So now this is the reconstruction of the biliary duct, and I show you a robotic video later, and you will see how much easier this part is in robotic surgery. So this is really something challenging in laparoscopic surgery, because after 4 hours of resection, now you have to concentrate again for the reconstruction, and this is really easier, to my opinion, in the robotic fashion. The stent is used, it stays in place. Normally it goes out automatically, so it's via the stool. We do not do in laparoscopy external stent. So it's almost finished, the reconstruction. As you can see here, it's really difficult to do it. We use here 5/0 sutures, and sometimes the angle is very difficult for making the knot, and this is something that is really much easier in the robotic fashion, as you will see in the next upcoming video. So this is really difficult because you can see we have no angulation. It's really hard to make the knots. So it's now almost finished. Then normally we fix the jejunal loop here again for not to make too much tension on the anastomosis. You can see the hepatic artery, and the stent is taken out in this case, so it's not staying inside. Here's the finished anastomosis. We normally put a small tissue there, like a swab, and control after finishing for the pancreatogastrostomy. We take it away and look whether we have some yellow staining in this area. So pancreatic anastomosis, laparoscopically, I told you that in many cases we do a hybrid resection. We use a small incision, and Kirill probably has seen this when he was visiting us. Small incision where we take out the specimen and we do then do the reconstruction of the pancreas anastomosis via the small incision. This is very safe. We just compared this data with some other centers who do full laparoscopic resection or robotic resection, and our results are really excellent as far as mobilization and low fistula rate. But you can also do it technically with a laparoscopy. Here you do this is the suture here that we are doing on the corner stitch here. Then we do a dorsal incision. This is again our purse string suture that I showed you in detail before. We do it outside here in this case. In this case, we do not do an anterior incision in the stomach. We just push it in into the stomach. So here you can see again anterior incision. You pull it up far. It's on the back wall. The assistant is pulling it up, and the surgeon is closing the posterior purse string suture. In this case, we do not use the single sutures for reinforcing the anastomosis. It's just a simple purse string suture. As you can see here, this is the invaginated pancreas. The assistant is pushing it up. We have full control that it's far invaginated, and then we use the we take the put it into the stomach, and we close the anterior incision again. So this is a far invagination of the pancreas. And for this, of course, pancreatogastrostomy is much easier than jejunostomy. It's a simpler anastomosis for laparoscopy. I prefer it in laparoscopy because it's really much simpler than the duct mucosa anastomosis, very complex in laparoscopy.
Looks very nice and very beautiful. Looks very nice, beautiful, and very safe, you know.
Yeah, it's a safe anastomosis because it's simple. And then we use a clip. This is a barbed suture, as you know. Different companies make it. So then we in the last phase we do the renojejunostomy. We put up the loop, and it's fixed on the posterior wall, and we do a running suture. It's nothing complex to do this.
Your laparoscopic tower is Olympus on this video, yes?
I did not understand you, sorry. This is
the laparoscopic tower used on this video, is it Olympus?
Olympus, yes. Yeah.
I recognize it by color.
Yeah. Yeah, it's we have a very good cooperation. As you know, Olympus is close to us in Hamburg, European headquarters, so we have good cooperation with this. So now it's finished, and we again use a clip for fixing this. So this is the inframesocolic. The colon is above. Inframesocolic reconstruction. We go through the colon, through the mesocolon, and then we put drains to the here to the biliary anastomosis, and we put drains to the pancreatic anastomosis. We always use drains. I know there are some publications that people do not use drains anymore. We use drains. And then this is the end, and we remove the specimen either via phalange incision or via enlargement of one of the pores. This is just an example of a portal vein resection. So this is something that Dr. Bausch, who is now professor at Bochum University, he was my first attending. He did this operation, and this is an IPMN, main duct IPMN total pancreatectomy. This is just to show you that it's feasible to do a laparoscopic portal vein resection. I told you we don't do it routinely, but this is just an example to show you that it's feasible. You can see here, this is the these are laparoscopic bulldog clamps. We clamp it out, and then we cut here the portal vein. The splenic vein is already cut, I have to tell you. Otherwise, it would be more bleeding. And now we remove the upper part of the and now we suture the posterior wall of the portal vein. This is 5-0. We approximate it, we put a little another bulldog to hold the suture. And then we go inside, and then we do the posterior wall. In this case, I mean, you can always open via a small midline incision to if there's a problem. This is a very fast approach. So we open it up after reconstruction. So this is now the posterior wall, and then we do the anterior wall.
Is this clip, it's brown Esculap clip?
You mean the bulldog? The bulldog?
Yes, he means bulldogs. Yeah.
Bulldog is Esculap, yeah, Esculap. When we close it and we open up the lower part and the upper part, and then you can see there's not much. It's not. It's quite good result. Okay.
Thank you, Professor.
Very nice. Thank you for this wonderful video. And there are some questions from our audience. Please realize them.
So we have some questions in Facebook group. Yeah. So the first one was about, as I remember, the best candidates for Labview procedure. So did you?
So when we started with the laparoscopic program, we did only cystic neoplasm, small EPMN, neuroendocrine tumors. So this or duodenal tumors or distal biliary tumors. So no large pancreatic tumors. And we did almost, I think, 50 or 60 cases until we did the first cancer. So I think this is a good indication for the beginning. And then when you have a good experience, you can start with the cancer.
But did you have some indication for lab procedures? So it's not a borderline tumors, yes, as I understand now, yeah, for cancer.
Yeah. So the first, the good indications are when you start it as cystic neoplasms, neuroendocrine tumors, distal biliary cancer, small distal biliary cancer, and duodenal cancer, because then you have no problem on the mesenteric portal axis.
Thank you. Another question about neuroendocrine tumors. Do you perform or know any role of lymphadenectomy in neuroendocrine tumors of pancreas?
It depends on the Ki-67 index. So if it's a low Ki-67 index, below 5%, we treat them locally, sometimes with enucleation. If it's higher, 5% or higher, or a neck, then we do a formal oncologic resection with lymphadenectomy.
Another question from
There was
Professor
one question about laparoscopic and hand assistant procedure. So, do you use hand assistant? Did you ever use hand assistant approaches in the pancreatic surgery?
Yeah, we never used hand-assisted approach, but we used hybrid approach. So we did the resection laparoscopically, and then did a small incision in the midline, and did the reconstruction via the small incision. We took out the specimen, and we do the reconstruction with a small incision. This was our first experience, hybrid operations, but never hand port, because the hand port is a problem. With the hand port, you have no visibility. The hand is taking so much space that you lose a lot of visibility. So we use it for living donor resection. Dr. Labview is using it, and I'm also using it for living donor resection. If we take out the kidney in the end of the operation, we take out the kidney. It's good to shorten ischemia time, but we don't use it for pancreatic surgery.
We have question from Alex.
Артем, я не слышу тебя.
Pancreatectomy.
Артем, еще раз, потому что не понял.
Sorry, the complication, the level of complication between distal pancreatectomy and enucleation.
The fistula rate of enucleation is much higher. It's almost 50%, but these are almost always self-retaining pancreatic fistula. So the patient needs a drain, and in most cases is finished after maybe, let's say, 2 weeks of fistula. If there's a persistent fistula after enucleation, we now have established a very good cooperation with our gastroenterologists. They do transgastric drainage of the liquid collection.
You mean transgastric drainage? Or
yeah, transgastric. Yeah. So we pull out the drain,
like in acute necrosis pancreatitis, yeah?
Like in pseudocyst or necrosectomy. So you have to wait for 2 weeks to get a good border of the liquid collection.
We saw the fantastic technique you used during the searing the vein, and the nice anastomosis and very great surgery. And one question about it is from our YouTube chat. Maxim Siliverstov from Russian Federation asks you about what about thrombosis? Is there
Ilya?
So the question, if I understand you,
I'm sorry. I'm from the mobile internet, and I said that was very nice technique of your hand acute anastomosis, vein anastomosis, and Maxim Siliverstov asks you, what about thrombosis after the vein reconstruction, and are there any protocol of prevention for laparoscopic or during the laparoscopic or robotic operations?
Yes, good question. So we know.
The question is about thrombosis after the vein reconstruction.
Okay, I understand. So what we do normally, we flush the vein. This was not in the video. We flush the vein with a little heparin, If it's closed on the upper and lower part, we flush it, a little heparin locally, and after the operation, the patient gets heparin for 5 days, and the PTT, partial thromboplastin time, is between 40 and 50 seconds, only very moderate anticoagulation. And after 5 days, we stop it. We don't continue. We just use a low molecular heparin because we know from pancreatic cancer that the patient should get it for 3 months, but it's every patient, not depending on portal vein resection.
Okay. We have one more question. Is any difference in oncological resection between open and Labview procedure?
There should not be a difference, to my opinion. So if it's, I told you we have limitations in borderline resectability or neoadjuvant treated patients, we do not do laparoscopy. But for primary cancers, if there's no risk of reconstruction of the vein or the artery, we normally do not intentionally operate patients who need a portal vein resection. Sometimes it's during the operation, but if we really see it in advance, we would do open operation. So this is our protocol here.
Okay, thank you. I think we get in robotic lab procedure.
Okay. Okay.
Mikhail?
So this is a robotic Whipple. Kirill told you that we have a robotic system since several years now. This is a main duct EPMN with worrisome features, large pancreatic duct. This is our trocar placement. We have an XI system. This is assistant port. Then we start off with opening up the duodenum, the Kocher maneuver. Here you can see the completion of the Kocher maneuver. Then we go down to the vein. This is the gastroduodenal ligament. We do the lymphadenectomy on the upper border of the pancreas. Here we do the lymphadenectomy along the vessels. This is the hepatic artery. This is the gastroduodenal artery that we are preparing for dissection. Here you can see the gastroduodenal artery. And the advantages you can see now here, we clamp it because we want to avoid cutting it when we have a Dunbar syndrome. So we clamp it with clips or with a small ligation. Here you can see ligation in addition to the clips. And we cut it. And we continue lymphadenectomy here underneath the artery. This is here the duct, biliary duct. Cut it. And here you can see the it's an atypical right hepatic artery that comes out of the mesenteric artery. Do lymphadenectomy here. We prepare the atypical right hepatic artery. In any case, in laparoscopy and in robotic surgery, you need a good imaging of the arteries because you cannot feel the pulse. You know, we have to know in advance where your vessels are. So then we prepare it towards the pancreatic head. So here we finish the Kocher maneuver, pull up the duodenum. This is now the lower part, the descendant part, 3 and 4, and we go towards the mesenteric root. Now we prepare the lower part of the superior mesenteric vein. We go here, this lower part of the pancreas. We go underneath the pancreas. Here we cut the duodenum, post-pyloric duodenum. This is done by the assistant. You can use a robotic stapler, but it's for economic reason we use a laparoscopic stapler. Then we cut the pancreas. There are different methods of cutting it. So one is by monopolar hook, or the other one is by incision with scissors, or normally we cut it like this. Then we prepare the mesopancreas along the vein. Then we go from here. The pancreas is pulled over the pancreatic head to the and now we go here. There are some branches. Go to the artery, superior mesenteric artery. These branches have to be cut or divided. They cut the mesopancreas. So this is the difference between the laparoscopic approach. We do everything from above. So we do not go underneath the colon here. So we pull through the whole mesentery to the right side without cutting it. Here we go along the superior mesenteric artery. But it's not divided.
It's like a robotic ligature, yeah?
Yeah, the robotic ligature. Yeah. And we now go here to the top, finish lymphadenectomy along the artery, and we want to now preserve the right hepatic atypical artery, which comes here. Here you can see now the connection between the right hepatic atypical artery and the superior mesenteric. Got it. And now it's finished. And this is after resection. And now we pull through the specimen. This is some finishing lymphadenectomy along the hilum. Okay, we take it out. And then now we mobilize it. Here, this is again some lymph node between the artery and the vein on the left side already of the artery. Okay, so now it's almost finished. Some more lymph nodes in this area. Okay, now all the lymph nodes are actually removed towards the celiac trunk and along the hepatic artery, the right hepatic artery. There. Okay, now it's finished after lymphadenectomy, and then we do the reconstruction. This is some variants. This is the Bilionteric Anastomosis, and you remember the laparoscopic approach. Now this is a robotic approach. We normally fix the jejunal loop on the liver. Again, this is a very small duct, and you can see here now the advantage of the robotic reconstruction. It's much easier than laparoscopic. Here we do the anastomosis, the small duct here. This is the corner stitch. And the assistant now is pulling up and we do a running suture. This is a very thin barbed wire. But normally now we do single reconstruction, 5-0 single sutures.
And as I remember, in open surgery, you use interrupted sutures for small ducts, yeah?
Yes, we also now, this is just a video, one example. I show you the next biliary reconstruction in this video will be single suture. So if you have a very thick biliary duct, you can use this barbed wire and the continuous running suture, but I prefer single interrupted sutures to prevent secondary stenosis of the anastomosis. This is a little bit more firm suture. You can handle it better because the robotic instruments sometimes lead to a breaking of the suture. So this is a little bit more robust for the handling of the robotic instruments. So now this is the continuous suture reconstruction, and it's finished. We just cut it, and there's another one which is single suture reconstruction, 5-0 PDS, interrupted. So the assistant is pulling it up to reduce tension between the biliary duct and the jejunum, so it's not going too much tension. And now the anterior wall.
Professor, if you have the same opportunity to choose lab or robotic, what do you prefer?
To be honest, we now completely switched to robotic surgery because we have the reconstruction is much easier for the surgeon. So I think for the resection, it's probably safe to do both. But for the reconstruction, it's much more feasible to do robotic reconstruction. It's easier. This is a case of a pancreatogastostomy. Nowadays, we almost always now use pancreaticojejunostomy for robotic reconstruction. We do duct mucosa anastomosis. I have another video. I don't know if I sent it to you, but we have another video for duct mucosa anastomosis that I'll be happy to share on the platform. If we don't show it now, I can share it otherwise. So this again, pancreatogastostomy. You have seen it now several times. Corner stitches of the pancreas. Again, very small pancreatic duct. In this case, corner stitches, and now dorsal incision, invagination. and we put through the pancreas is pulled into the stomach. Again, you can see it here, and then we just close the posterior incision. And then we close the anterior incision. So this is a pancreatogastrostomy, but as I told you, now we really like also the jejunostomy in robotic fashion that is much more complex, but it's feasible by the robot. So we do this. Here's the jejunostomy. It's a duct mucosa anastomosis. We do a so-called blue guide anastomosis. As a bloom guide anastomosis, so we do this is a 4-0 MH needle, a large needle. We do a posterior fixation, and then the needle stays on the suture for the anterior completion. We go here through the parenchyma. It's a mattress suture. And then we do the duct mucosa anastomosis. Yeah, and this is something you can now really see what is the benefit of the robotic surgery.
Did you ever use virsungostomy as the method that can be helpful in avoiding all the fistulas?
What did you say?
Ileum. Did you ever use the virsungostomy from the ileum after this reconstruction? I mean, when you make the anastomosis on the catheter, and then you just make the stomy from the abdomen.
In this case,
like
we leave
Japanese surgeons may do it.
Yeah, no, we never used it, so we don't use it. But we have been using external stents for this reconstruction. In some cases, we do external stenting. This external stenting is sometimes it's a long drain that goes out via the jejunum, and we just measure amylase or take out the whole amylase. Not an internal stent like this, but external stent. So this is now the duct mucosa part, and then we finish the anastomosis by completion of the anterior mattress from the bloom guide anastomosis. This suture is actually left and right of the stent, so it's again closing a little bit pressure on the stent in duct mucosa anastomosis. It's, the one side is left and the other one is right of the insertion of the stent. And this is now the upper part. And then we finish by doing two sutures on the corners.
This is PDS sutures. Yeah?
This is 4-0 PDS. Yes. And now this is the corner stitch, last stitch to take away the tension of the corner of the anastomosis.
Professor Keck, and you, as I understand, you start performing this anastomosis after robot, yeah?
Yes,
when
only we don't.
Robot?
I think it's laparoscopically it's almost not feasible, but robotically it's very nice. And I did some anastomosis with Ugo Bocci from Pisa, and we did, and he showed me this anastomosis. It's really a very good anastomosis. So I'm preferring actually doing this now for reconstruction. Now the last step is the as you have seen the dual renal check-anastomy. I think this can be cut, or we can probably skip it. Okay, that's it. Oh no, wait 1 second. I show you a portal vein resection. So this is a portal vein resection that has been done again by Dr. Bausch. This is here a graft that he put in. Again, laparoscopic bulldogs in the lower and upper part. And this again is an end-to-end anastomosis. Here is a tumor infiltrating. This is a lower infiltration in the mesenteric root. As you could see, it's below the confluence. This is the tumor. And then we do an end-to-end reconstruction. You can see it's much faster, of course, than the laparoscopic reconstruction. Much easier. Open up above, open up below. And this is a low infiltration because here you can see it's below the insertion. Here's the patient after reconstruction. We take out the specimen here, and it was a very good course of the, not everybody is leaving that early, but this is a good course of the post-operative care. Thank you.
Dankeschön. It was amazing. We are very grateful that you took the time to be with us today. An amazing presentation, great videos. I hope you also enjoyed. And any question from YouTube, our audience?
Well, we are very grateful for you, Professor Keck, because it's a wonderful experience, and when we begin our project, our main task was to make our audience to give the information to our audience about different types of procedures, about the different approaches, and I suppose that your experience, the experience of very experienced surgeon and a very experienced mentor, will be very important for not only for students and residents, for attending doctors, and for everybody who is involved in the very, very difficult surgery, pancreatic surgery. And we would like to ask Grigory to tell us some words about the clinic, because the former USSR audience know a lot about you, and some doctors from Ukraine work in your clinic, and you always very, very hospitable for all doctors who want to learn from you and to see the modern approaches in the pancreatic, and not only pancreatic surgery. We know that in Germany you are the visceral surgeon and very the very skilled surgeon, and you work in different areas of surgery. And we would like to ask Grigory to tell the audience some words about your clinic, to tell us some words about Professor Keck and some plans of your clinic. And after pandemic period, will it be the possibility to come to you and learn to you and to just receive some experience from you and from your chief and from the doctors from your hospital?
I'm here since 6 years in Lübeck University, in University Clinic Schleswig-Holstein Campus Lübeck, and I worked together with Professor Keck in Freiburg University Clinic. Our clinic is big with 45 doctors, and we have general visceral surgery. We have thorax surgery. We have transplantology in our clinic and vascular surgery. And we do rotation between this clinic. It's very good for your experience as a surgeon, as a general surgeon with bright experience. And my interest here is transplant surgery, and pancreas and liver surgery. And we had, before Corona time, we had a lot of guests from Georgia, from Azerbaijan, Ukraine, and Russia. And it's very good for these people, for our clinic. It was interesting too. And you're welcome to our clinic because of Professor Keck. Hospitality and what can I tell you more? Ilya?
Thank you very much. Thank you very much. And dear Professor, thank you for your time. It was a great experience, and I suppose that the modding possibilities gave us the opportunity for this webinar to be in the internet forever. So any person who wants to know about pancreatic surgery and who wants to see how you do it, we can just click on click and just see it in the internet. So thank you very much. I liked this webinar. It was very great, and I I am in a very special. It's a very special time for me because I am COVID plus. I understand it about this several days ago, and just now I'm trying to. I have here some fruits, but I don't understand the taste. But thanks God, I can watch with the webinar and I can hear you. And thank you very much for this evening. I believe then after the pandemic, we will come to you and see you in the real life, and you will learn us, and you will learn a lot of surgeons, residents will study from you. So thank you very much. Outstanding surgery, fascinating webinar. Thank you.
I congratulate you to this nice idea. I really enjoyed it, and it was a lot of fun for me also to share it via the internet. And thanks a lot for the opportunity to make this possible. I really enjoyed it, and I really see that that you are doing a good job in doing this, and I'm sure that many people will enjoy it. And anyway, as Gregory said, as soon as this pandemic is over, we can meet again in person, and I'm looking forward to that and share our experience.
Thank you very much. Unfortunately, we are three today because our friend's father had died. Ilya's father had died several days ago, and he can't be with us today. And one more time, Ilya, condolences, мы тебе очень все соболезную. And Grigory and Professor Keck, thank you once more very much. And I will announce the next webinar. The next webinar will be about one more webinar will be about pancreatic cancer, and we will speak about the open and laparoscopic pancreatic laparoscopic Whipple procedure. So we will show you the video of open and then laparoscopic, but the stage of resection. So without reconstruction, because about the reconstruction, we are planning to make the separate webinar. So thank you very much. Thank you our guests. Thank you guys, and see you again. Следующий вебинар будет, еще расскажу по резекционному этапу ПДР открытой лапароскопии. Счастливо. Thank you very much. Goodbye.
Thank you.
Bye-bye.
Bye-bye.